Greetings, everyone. Let me start with a simple question. If we deploy artificial intelligence in Nigeria healthcare system tomorrow, who is going to be the first to benefit? Will it be a mother in a rural primary healthcare center in Yobe State with no electricity for 3 days or no doctor on site? Or will it be a patient in Lagos Teaching Hospital with fiber internet backup generators and specialist consultants? If we are honest, we already know the answer, and this is exactly the problem I want us to talk about today. My name is Clement, and today I want us to talk about something that keeps me up at night. How do we bring artificial intelligence to a healthcare system that is one system but three different words? This presentation is based on a mixed method study I conducted across 24 facilities in 3 Nigerian states, Lagos, Kano, and Enugu. Let me show you what we found. First, I would like us to go through the agenda, and here is what we're going to cover in the study. I'll also walk you through our research methodology, the digital chasm we uncovered, and what the frontline health workers told us they actually need. And after that, I'll present our tiered AI alignment framework, a 36-month roadmap, and end with a clear call to action. By way of introduction, AI has been called the great equalizer in global health, and indeed, in high-income settings, AI now helps read retinal scans, interpret chest x-rays, and predict sepsis. But here is the problem. Fewer than 3% of artificial intelligence clinical trials have been conducted in sub-Saharan Africa. When tools built for wealthy hospitals are simply exported, they fail. Not because the algorithms are wrong, but because the electricity, internet devices, and digital literacy are not there. Without deliberate equity-focused strategies, AI will not close the gap. It will only widen it. So let me show you what we are dealing with. Nigeria has over 220 million people and a constitutionally mandated three-tier system. At the bottom, roughly 30,000 primary care centers, mostly rural, staffed by community health workers. Only 8% of those have reliable electricity. 1/3 have any internet, almost no facility-owned computers. In the middle, about 4,000 secondary hospitals, general doctors, basic x-rays, and lab moderate infrastructure. And at the top, 150 tertiary teaching hospitals, sitting with specialists, CT scanners, reliable power, broadband. These are not just different levels. These are different words. A primary care center, for example, in Yobe State, may have no electricity for 3 days. A tertiary hospital in Lagos has got gigabyte fiber and multiple backup generators. Any national AI strategy must account for this, or it will be relevant for the majority of Nigerians. So we designed a study to understand what is actually feasible. We conducted a convergent mixed method study across Lagos, Kano, and Enugu states. 24 facilities in total, 12 primary care centers, 8 secondary, and 4 tertiary hospitals. We did 2 types of data collection. The first, a facility artificial intelligence readiness audit covering power, connectivity, hardware, software, and workforce digital literacy. The second was 48 semi-structured interviews, 2 per facilities with clinical and administrative leads. We visited each facility twice, one announced, one unannounced. Translations were backed-checked. Ethics approval was obtained from both Nigerian and Swiss boards. The digital chasm, and the evidence is stark. Let me give you the headlines. Across these 3 major states, power is the binding constraint. Only 8% of primary care centers have reliable daily electricity, and compared to tertiary hospitals that has got about 100%. Second is connectivity bifurcates the system. 1/3 of primary care centers have no internet, and where they do, staff often pay for it from their pockets, and they do that personally from their own pockets. And in secondary and tertiary, they have full connectivity. Smartphones are personal assets in most of these facilities, and they don't belong to the primary healthcare centers. Only 34% of these primary healthcare center staff own smartphones, and compared to tertiary hospitals that's got 92% of their staff have got smartphones. Digital literacy is lowest where it is most needed. Only 41% of primary care staff could complete basic tasks like uploading a photo, but here it's an important nuance. Younger community health workers under 35 did much better. This suggests a generational shift, not a permanent barrier. It's good to keep that in mind. Every single inter-tier comparison was statistically significant, and this is a real measurable chasm. Next, we're going to look at the stakeholders. So What do frontline workers actually want? At primary care centers, the number one request was triage and referral support. One community health worker in Enugu told me, I see a sick child. Is this malaria, pneumonia, or meningitis? An AI that helps me decide what would save lives. And at secondary hospitals, the top priority was diagnostic imaging support. A medical officer in Lagos said, we have an X-ray machine, but no radiologist. Artificial intelligence for determining tuberculosis or chest X-ray would make a significant difference to them at that level. At tertiary centers, their ask was quite different. They want advanced imaging triage and predictive analysis. A radiologist in Kano, for example, suggested we have a waiting list of about 300 for CT, and artificial intelligence that flags the most urgent cases would let us scan in order of need. And across all tiers, the same conditions appear. AI must be free or very low cost, work offline, not require any new hardware, or augment, not replace clinical judgment. I think we can now go to concerns and barriers. We also asked about concerns in the course of our study. 3 came up repeatedly. First was trust, accuracy, and reliability. A consultant in Lagos, for example, said, if the AI is wrong, who is responsible? Is it the doctor, the government? Until that is clear, I cannot trust it. The second is data privacy and security. Administrators at secondary and tertiary facilities worried about patient data, HIV status, cancer diagnosis, leaking through an AI hack. Third is maintenance and sustainability. A primary healthcare center coordinator in Kano told us, we have received donated laptops. Before, after 6 months, they break. No one comes to repair, and who repairs AI? And interestingly, fear of job loss was almost absent. Only 2 or 48 participants raised it. 2 nurse said, AI cannot hold a baby's hand during delivery, so I'm not worried. When asked about delivery models, preferences were clear. Primary care centers want text messages, applied phones, no smartphones required at this level. At secondary tier hospitals, they want tablet-based offline tools. And at tertiary, they want integration with existing electronic medical records. We now go to the tiered alignment, AI alignment. So we decided to synthesize all of this into a tiered AI alignment framework for short, TAF for short. And we arrived basically at 3 strategies. 3 resource levels, 1 principle, match artificial intelligence complexity to facility reality, and I'll be happy to walk you through in my subsequent slides. The first one is tiered AI framework, alignment framework, tier 1. At the primary healthcare centers, we propose ultra-low resource artificial intelligence. That is, for primary healthcare centers, what we propose is ultra-low resource artificial intelligence. The technology will depend on USSD or short messages, which is SMS, without need for smartphones or no internet. A community health worker sends a coded symptom data from any mobile phone. A central server hosted at state level with reliable power returns a triage recommendations in seconds. This clinical scope includes childhood illness, algorithms, maternal risk, scoring, and danger sign identification. There's no need for imaging at primary care center level. This will not require no imaging devices. The literacy adoption uses numerical menus and voice prompts in either Hausa, Yoruba, Igbo, or Pidgin, and there is evidence this works. An SMS-based artificial intelligence triage system in Kenya reduced maternity mortality rates by about 27% in intervention zones. So it's something we are very sure that this will work if adopted at our primary healthcare level. For secondary hospitals, we propose edge-assisted diagnostic AI. This is going to be a lightweight artificial intelligence models which run entirely on a tablet or laptop, preferably offline. Only model updates require connectivity from time to time. Clinical applications could include chest X-ray interpretation for tuberculosis, pneumonias, ultrasound guidance for gestational age and laboratory result pattern recognition, Power is manageable. Batch processing on charged devices with generator backup generally available. Evidence on device chest X-ray, AI has shown over 90% sensitivity for tuberculosis in South Africa and Zambia. Per facility, I think the initial cost should be somewhere in the range of about $5,000 to set up for each of these facility. And lastly, we're looking at tertiary. For tertiary centers, what we propose is a full stack human in the loop AI. This is going to be a full deep learning models integrated with existing electronic medical records, active learning loops where specialist feedback improves models over time. The applications would include CT stroke detection, MRI tumor segmentation, and predictive analytics for inpatient deterioration. But with one non-negotiable rule: human in the loop. A radiologist must review and sign off on every AI-generated finding. The clinicians is ultimately responsible, but the AI provider has liability for algorithm defects. The identified data from tertiary can retain models for Nigerian populations, and per facility initial cost is approximated to around $200,000. So I'd like to just quickly go through the cost summary. Just to summarize the cost picture, for a primary care center, we'll be looking at $500, and for secondary facilities, we'll be looking at $5,000, and about tertiary center, we'll be looking at initial cost of $200,000. And importantly, all tiers prefer open source audited models hosted on Nigerian servers. This prevents vendor lock-in and enables local modification. Now, going to implementation, we propose a 36-month equity first roadmap and implemented in 3 phases. The phase 1 is going to be the foundation, which is the first to the 12 months, which is estimated at about $350,000. And we're looking at national artificial intelligence and health policy, data privacy and liability frameworks, technical standards, and pilot facility selection. Phase 2 will be the pilot phase itself, which is going to be between 12 to 24 months, with the introduction of USSD triage live in at least minimum of 10 primary healthcare centers, offline X-ray, AI in 5 secondary facilities, governance operational at 2 tertiary centers for midterm evaluation. And finally, phase 3 would be scaling. That is scaling it now up to about 100 primary care centers, 50 secondary hospitals, and 10 tertiary hospitals across a minimum of 12 states, 1 per the geopolitical zone. Rigorous impact evaluation on mortality, referral appropriateness, diagnostics, accuracy, and cost effectiveness. Total investment over the 3 years will be looking at a minimum of between 5 to 6 million USD. To put that in context, that is 0.2% of Nigerian annual health budget. That is not a cost problem. It is a priority problem. And let me close with this. One size fits all AI will fail. The 3 AI alignment framework offers a practical, evidence-informed alternative: text-based triage for primary healthcare centers, edge-assisted diagnostic for secondary hospitals, and full-stack governance heavy artificial intelligence for tertiary hospitals. What is missing is not technology. The algorithms exist. The open source models are available. What is missing is the political will to be able to, and the regulatory clarity, sustainable financing, and deliberate commitment to equity. If Nigeria succeeds, we become a model for every other country with internal health disparities, such as India, Indonesia, Pakistan, Democratic Republic of Congo, Ethiopia. If we fail, artificial intelligence becomes another luxury for the urban few. The choice and the investment must come now. Thank you very much. I would like to now take questions, and if you're watching this on YouTube, please endeavor to subscribe to this channel, and you can also take your questions in the comment sections, and I will be happy to respond to them. Thank you very much for your time. See you in the next one.